All right, now we're going to talk about the organism Nocardia. This is the first of our filamentous organisms. There's actually only two that we talk about in this curriculum. So there's Nocardia, and the other one is Actinomyces. Actinomyces israelii is the most notable of the Actinomyces organisms. We'll talk about this one later in your curriculum, but both of them are filamentous, and we have to find ways to tell them apart. And the main way is that Nocardia is partially acid fast, whereas Actinomyces is just gram-positive. So what do I mean by acid fast? Well, basically, normally we use the acid test to detect mycobacteria because they have a unique cell wall structure, which we'll talk about in the mycobacteria video. But Nocardia are partially acid fast. This occurs in bacteria that have high mycolic acids in their cell wall, which Actinomyces does not, but Nocardia does. And these mycolic acids will trap this special dye to be retained in the cell wall. And they're the only organism that has this characteristic. So if the stem says partially acid fast, then the organism is Nocardia. It's the only possible answer, the only one. This image shows you what acid fast staining looks like. So you can see all these red threads. Those are your organisms. So it can be really useful for differentiating between the two filamentous organisms. And you can tell that they're called filamentous because look, they look like little wires, little filaments that are growing end to end. These are non-spore forming organisms because remember, we've already talked about our spore forming organisms and Nocardia isn't one of them. Some of the other biochemical tests that can be used to differentiate it in the lab are urease and catalase, for which it is positive for both. Urease is very abnormal for a bacteria to have. We don't know why this organism has it. There's no medical significance, but it is a way that you could technically identify this organism. It is catalase positive, and that is necessary for its respiration because these are obligate aerobes. They require oxygen. We generally find these in the soil and dust transmission. So that's kind of how you get it. You're going to get it by breathing in or by traumatic implantation, i.e. injury, where the soil is kind of driven into the skin. So I say no toxins or specific virulence factors. And I can hear the busy fingers of med students typing away right now saying, but Dr. Richards, you say in your notes on page whatnot that its virulence factor is to avoid phagocytic killing. Well, yeah, of course that is. All of the microbes want to avoid phagocytic killing. It sounds very unpleasant, but that's not really a virulence factor per se. That's just a really good evasion strategy. The primary virulence factor is the ability of pathogenic strains to avoid phagocytic killing. But, you know, that's what all organisms want to do. So how does Nocardia do it? Well, Nocardia has catalase and a superoxide dismutase. So that basically protects them from the metabolites that neutrophils and macrophages use to kill the organisms that they engulf. So therefore it can replicate within the macrophage for a bit, preventing fusion of the phagolysosome like we've seen in other organisms, preventing acidification of the phagosome, and avoiding acid phosphatase mediated killing. So it's a pretty useful strategy. Okay, so what are the diseases that it causes? These are more often found in patients who are immunosuppressed. So, you know, patients with HIV and AIDS, certainly cancer patients, transplant patients, etc. But other people can get nocardia infection. And there are really only two diseases you need to think of: cavitary or bronchopulmonary pneumonia and cutaneous. So let's start with the bronchopulmonary because it's much more associated with the case that we're talking about today. So bronchopulmonary disease is basically caused by the inhalation of the pathogen from the environment. This occurs almost exclusively in immunocompromised patients. We're not going to see this elsewhere, especially when there's reduced T cell function, because remember, it has a phase where it can hang out in macrophages. Nocardia has a really slow growth curve. So it's kind of an indolent course at first, and the symptoms for this one can include your typical symptoms of pneumonia: cough, dyspnea, fever, and then eventually you'll get cavitation and spread into the pleura. When you're thinking about where you should actually consider nocardia, Really, nocardia should be part of your differential diagnosis when you're dealing with an immunocompromised patient experiencing pneumonia with cavitation, and especially if that patient shows dissemination of the disease to the brain, because nocardia has a particular affinity for neural tissue, and that leads to brain abscess formation. Now, that brings me to the next part of the story, cutaneous or lymphocutaneous lesions. These occur due to traumatic implantation, even in people with normal immune systems. And it produces what's known as a mycetoma. And a mycetoma is kind of a painless chronic subcutaneous infection where you get these draining sinus tracts. And primarily they're found on the feet by localized subcutaneous swelling with involvement of the underlying tissues, the muscle, and the bone. Now, remember earlier I said that it could disseminate to the CNS because it has a particular affinity for neural tissue. So sometimes what you could see is a patient comes in with, some sort of meningitis presentation, and then you find out, oh, look, they have a cutaneous mycetoma. And that could kind of spur you into thinking, oh, okay, maybe this is nocardia because it started with this lesion and then it disseminated to the brain. Now, this picture right here is a very special picture. It's a picture that is special to Rush. All of these leg lesions that we're seeing here are nocardia, every single one. This picture was taken by a colleague of my predecessor, and this leg belongs to the pedicab driver in Singapore that the colleague of my predecessor met. So what happened here is that this colleague was a microbiologist, and he was in the cab getting a ride, and he saw these lesions, and he said, I think that might be nocardia. And as he's riding in his cab, the cabbie is going downhill, and he's noticing that the pedal is like whipping around and whacking him in the back of the leg. So over the year, he got lots of injuries, and nocardia in the dust and the dirt got into his leg. So our intrepid microbiologist looked at the cabbie and asked to take a picture of his leg. And the cabbie said, okay. And he said, I'll make you a deal. I will have your lesions treated. If we go to the hospital, let's go to the hospital. I will pay for your treatment if you give me access to the pathology report. And obviously at this time, and this was many years ago, the HIPAA laws in Singapore were such that that was completely acceptable. So our intrepid microbiologist took our cabbie to the hospital where his nocardia, and it was in fact nocardia, was treated, and we got this fantastic picture. And the treatment that is most often recommended is trimethoprim sulfamethoxazole. So in this case, our cabbie was lucky because it did not disseminate up to the CNS. So those are kind of the two diseases that we associate with nocardia. You can diagnose it basically through looking at it microscopically using that partial acid fast staining. It has a really slow growth curve, so culture can be kind of difficult.